Okay, hi everyone. I'm Alex and this is Catherine, and welcome to Thursday teaching at MedTech. This is the first paediatric talk in our final series. So if you go to the next slide, we can see some of our learning objectives for today. Should we go to the next slide just to see the like the learning outcomes for today? Can you hear me talking now? Can people hear me now? I think I was having some mic issues. Okay, so I think I can be heard, but
Yeah.
yeah, okay. Okay, are we sorted now?
Yeah.
Okay, cool. Okay, I'll just start again then. So I'm Alex, and I'm here with Catherine. So we're from MedTech, and we're doing our Thursday finals session teaching, and this is the first of the paediatric sessions. So if we go to the next slide, we can look at the learning outcomes. So we've got an array of topics. I won't just read them out for now, but the way the structure of the session works is we give a question, just a multiple choice question. You guys have some time to answer it, and then we'll go through an explanation and talk a bit around that topic as well. So we can start with the first question. So we'll give you a few minutes just to answer this, and I'll put a poll out to answer the question. Okay, I think everyone's answered, so shall we? So the answer was C. So if we go to the next slide, we can talk a bit about neonatal jaundice. So, so it's increased bilirubin. So as we know, red blood cells, when they're broken down, they form unconjugated bilirubin, which is then converted in the liver to conjugated bilirubin, which is then excreted in the biliary system and urine. Fetuses and neonates, they have different red blood cells to more sort of like adults and older children, in the sense that their red blood cells are firstly more concentrated within the blood, but they're also more fragile, so there's an increased breakdown. On top of this, sort of fetuses and neonates have a less developed liver function, and fetuses, their bilirubin is excreted by the placenta. So it is very common for neonates to develop jaundice, and it's physiological between days 2 and 10. However, if the jaundice occurs within the first 24 hours of life, this is always pathological and needs urgent assessment. And either sort of, if it is physiological or pathological cause for the jaundice, if there is excessive build-up, you can get kernicterus, which is when excessive bilirubin crosses the blood-brain barrier and causes central nervous system damage. So you can get learning difficulties, cerebral palsy, and deafness as well. So thinking about the causes of neonatal jaundice, so we can split it into increased production and decreased clearance. So one of the more important causes for neonatal jaundice hemolytic disease of the newborn. And this is where the rhesus status of the mother comes into play when we're thinking about our sort of like timeline for like the obstetric timeline. So essentially, if the mother's red blood cells are rhesus antigen negative, and her first child has red blood cells that are rhesus antigen positive, there's going to be some cross-contamination of the blood at some point during the pregnancy. So if the fetus's blood gets into the mother's bloodstream, the mother's immune system is going to recognize the rhesus antigens as foreign and sort of form like a sensitivity to those rhesus antigens. So it's not so much an issue in the first pregnancy, it's in the subsequent pregnancies. If the blood from a later fetus that the mother has, which is also rhesus antigen positive, gets into the mother's bloodstream, then there's going to be an immune response initiated by the mother's immune system that's going to get into the fetus's immune system. And then within the newborn as well, that's going to cause a breakdown of the red blood cells, leading to the jaundice. Sepsis is also an important cause, as well as G6PD deficiency. In terms of decreased clearance, so important ones are like the extrahepatic biliary atresia, so it's sort of like a malformation in the biliary tree, as well as certain endocrine disorders. So if we go to the next slide. So your investigation, so you're going to do sort of like your routine bloods, but in terms of LFTs, you're going to sort of be looking at the bilirubin level, but then also comparing the conjugated to unconjugated to try and assess the cause. So that's where sort of blood group testing will come into it, the rhesus status, as well as direct Coombs test. If you're thinking sepsis is a cause, then you could always do a infection screen. And then thinking about the management, so there's a graph similar to sort of like the paracetamol overdose graph for when you actually treat. So it plots the total bilirubin level versus the age in hours, and then there's a threshold, and when it goes over the threshold, then you treat. So first line is phototherapy, as you can see there, with the UV lights, and then also in more serious cases, you can have exchange transfusions. Okay, so I think everyone's answered that. So the answer there was D. I can just see in the chat, so I didn't want to sort of speak when people were answering the second question, that there were some questions that came through about the previous question about, so one of the questions is why did you repeat the bilirubin level in 6 hours. So just out of all the answers there, it seems to be sort of you're not going to treat the patient, no indication to start antibiotics, so you're sort of left with either repeating the bilirubin level in 6 hours or discharging home. And I guess sort of because it's such a high risk condition and that level is quite high, it seems more sensible to repeat the level in 6 hours rather than just discharging. And then the other question was, even so, because she was 3 days old, isn't this physiological jaundice? Which it's hard to tell without doing further investigations, but it's entirely possible that it would be. But that still doesn't mean that you wouldn't get dangerously high bilirubin levels that you would need to treat if it reached the threshold. So that sort of treatment threshold is for both physiological and pathological jaundice. So sorry, we went back a topic there. So we'll go back onto this otitis media question. So if we go to the next slide, we can see why it wouldn't be sort of indicated for antibiotics quite yet. So it's otitis media because they had sort of the red bulging tympanic membrane, which sort of is quite typical. So common pathogens, so strep pneumoniae, haemophilus, and Moraxella. So guidelines say that you start the antibiotic on day 3 of symptoms, and I think this case was only day 2. So it's just something to learn. In terms of potential complications, key one is mastoiditis. So that's inflammatory of the mastoid bone. So it's really important to when you're assessing these patients to sort of like press on the mastoid, have a look at it, see if it's sort of tender to touch, if it's red, if the ear is sort of pushed forward. Other complication you get is chronic suppurative otitis media. So it's sort of an ongoing perforated eardrum for over 6 weeks, and you can get either with or without discharge. And you'd only repair the tympanic membrane if it's been perforated for over 3 months. So otitis externa, so this is more sort of the external canal is sort of red flaky skin. Sort of kids are like itching and sort of pulling at the ear a lot. So Pseudomonas is the common cause, as well as Staph aureus. So first line is topical treatment, so acetic acid, give topical ciprofloxacin, and I also learned that you can give steroid drops as well. If it doesn't respond to that, then you can give flucloxacin. And the key complication is malignant otitis externa, so it's where sort of the infection spreads to the temporal bone, cause osteomyelitis. Go on to the question 3. Okay, looks like everyone's answered, so should we move to the next slide? So it's interesting, the 2 options we went for, start IV, either starting IV fluids or continue with oral fluids. So we see on the next slide, so this is gastroenteritis. So first we go through some of the common causes, and then we get on to sort of, obviously it was good that everyone picked up that the hydration is key here, and that you don't jump straight in with like an antibiotic. So, you know, both options are safe, but, you know, oral hydration is more suitable if tolerated. So common causes, gastroenteritis, so viral, especially norovirus. And then I've just put some key ones here. Obviously there's lots, and I think for finals it is important to sort of go through them all to learn sort of the transmission routes, the intubation period, key symptoms. So I've got a few of the sort of high yield ones, but obviously this isn't the complete list. So in terms of E. coli, so you can get the sugar toxin from specifically the E. coli 0157, which you can develop hemolytic uremic syndrome. So that's so like hematuria symptoms. Shigella is also another bacteria that produces that toxin. Campylobacter jejuni, so this is from raw poultry, typically presents with sort of bloody diarrhea. And then Yersinia. So sort of complication from that is this lymphadenopathy, mesenteric lymphadenitis. Sort of other ones that you should really should know is the bacillus with the sort of rice that's been left out, salmonella, which is raw chicken. Staph aureus has this enterotoxin, and Gardnerella as well. So key principles. So as we spoke about, so continue sort of with hydration. It's really important. So this fluid challenge, so it's sort of not the giving the bolus of IV fluid. It's sort of in A&E, you'd give the sort of the child sort of sips of water or like cups of water every 5 to 10 minutes. And if they can tolerate that, then it's sort of reassuring that they would be able to sort of continue to hydrate orally. So you potentially think about discharging them. You definitely don't give anti-diarrheas and antiemetics, so like anti-diarrheas, like loperamide, just because it's sort of the body's natural response to these microbes is to sort of try and expel them. So you definitely don't want to like stop the body from doing that. And then you can give antibiotics, but only once you identify which bacteria it is. In terms of complications, so key ones are like reactive arthritis, so that's your triad. So that's sort of arthritis, urethritis, conjunctivitis, and then Guillain-Barré syndrome from the Campylobacter as well. Okay. So carry on with some other sort of like common pediatric infections, such as so this is just like URTIs, and sort of like we also speak a bit about pneumonia here. So tonsillitis, so strep pyogens. So you have the centaur and the fever pain criteria. If they meet this, then you start them on the penicillin for 10 days. Quinsy is an important complication, so there's peritonsillar abscess. They get this trismus, so their mouth's open and it's sort of they can't shut it. Sort of it's open for more than 3 centimeters and they can't shut it. And obviously there's certain indications for tonsillectomies if you have a certain number of episodes of tonsillitis in a certain number of years. Bronchiolitis, so very common in under 3, so it's RSV. And then high-risk groups, you can give the palivizumab vaccine as well. So viral-induced wheeze, we'll speak a bit more about sort of treatment of asthma, but so we'll come on to that later. Croup's an important one, so the parainfluenza, barking, cough, treated with dexamethasone. Epiglottitis is a very serious one, so haemophilus influenza B. The child will sort of be in this tripod position, really sort of sucking air in. If you do a chest X-ray, you can sort of see the thumb printing sign of the inflamed epiglottis. So they say that, so you sit the child up, and this is one of these emergencies, so you'd look to ET intubate the patient at this point. Whooping cough, it's a notifiable disease. Pregnant women and children get vaccinated, and you treat it with a macrolide. And then pneumonia, you typically treat it with amoxicillin and macrolide as well. Okay, shall we go to the answer? So it seems like we have a split in votes between B and C. So essentially, it's sort of like the fact that here that he's only saying mama and ball, so the two words, so it's a bit of like a loss in vocabulary, or like very small vocabulary for his age. So it'd be appropriate to refer to speech and language therapy, wouldn't be an urgent referral to paediatrics. So if we go to the next slide, so the milestones is obviously something you learn just like a few days before the exam, but they are important to know. I've sort of tried to put a bit of a slide together here with like the key points that maybe you can sort of just try and remember these and like sort of like commit these to memory, but then like, you know, these are high yield things, but maybe before the exam you want to have a look at the more like niche things. But I like to think of it as sort of like 1 month, 6 months, 12 months, 24 months. At 1 month, so you expect them to lift head, be able to track objects, coo and recognise their parents. So 6 months, sit up, pincer grip, babble, recognise strangers. 9 months, so they're starting to crawl, inferior pincer grip, saying mama and dada, playing peekaboo. 12 months, walk, pincer grip, words, imitate, and then 24 months. So use 2 steps, use 2 hands, 2 word sentences, and start to stat blocks. So it's sort of the fact that 24. So this child was 2, and they were only saying sort of like they only had 2 words in their vocabulary, or they weren't actually putting sentences together, and we'd expect them to sort of have a bit more than that. And then just the other key thing is that younger siblings do tend to walk later than older ones. Yeah, there might be some sort of like psychological reason behind that rather than sort of anything biological, but there you go. So next slide. So these are sort of like red flags. So I think these are sort of important to learn as well. Sort of just to sort of commit these to memory for the long term rather than just sort of cramming before an exam. So any regression is pathological. In terms of gross movement, so stuff like not being able to sit unsupported by 12 months, not being able to walk by 18 months, not being able to run by 2 years, not being able to speak by 2 years, not being able to smile by 10 weeks, and then sort of not being able to sort of having a hand preference before 18 months. In terms of weight, so I have just written this out. I don't know if I've sort of written it in a bit of a confusing way, but if their weight's below the second centile, then that's always a red flag. If they're in the bottom decile, so bottom 10 centiles, and they drop 1 centile, that's a red flag. If they're in the sort of middle decile, so 1 to 9 decile, but they drop 2 centiles, and then if they're in the top centile, the top decile, and they drop 3 centiles, and that's also a red flag. So I think that's the end of the milestone section. Go to the next question. So I'll let Catherine take over from here.
Cool. So let's move on to question 5. I'll just give you a few minutes to read through it, and then we can talk through the answer. Cool. So moving on to the answer. So the answer here was C. So this boy is 7 years old and he's presenting with kind of symptoms of asthma. So the first kind of thing that we do would be spirometry with bronchodilator reversibility. So in children that are more than 5 years, that's the first line test to support a diagnosis of asthma. We can use fraction of inhaled nitrogen if as you use as a second line test, but we don't often need to use chest x-rays unless you think that there's something else going on as well. It should also be supported by objective evidence of like variable airflow obstruction, so i.e. spirometry. So spirometry measures the FEV1 and the FVC, and a diagnosis of asthma would be supported by an FEV1 to FVC ratio of less than 70% and a reversibility of more than 12% or equal to 12% in the FEV1 after they've had some sort of SABA, so like a salbutamol inhaler or something like that. Cool. So moving on to question 6, I'll just give you a few minutes to read through it and answer that one. Cool. So moving on to the answer. So in this case, the answer was D. So we'd give this boy inhaled salbutamol with a spacer and some oral steroids as well. So this question was about asthma exacerbations, and A lot of the time in finals, they will ask you about severity criteria, or not necessarily specifically ask you about severity criteria, but they'll give you some numbers like they did here, and then they'll basically ask you to put the pieces together and kind of move about on with the treatment. So in this case, the boy, his saturations are 96, his breath rates are 26, he's got wheeze, but he is talking in full sentences. So in this case, we're talking about a mild to moderate asthma exacerbation. Obviously, this would be severe and this would be life-threatening. So if you want to take a photo of that, you can do, but it's often on kind of lots of websites anyway. Cool. So in terms of treatment, the immediate management in any sort of asthma exacerbation would be to give a patient high flow oxygen, especially if their SATs are less than 94%. You'd give them a bronchodilator, so like something like salbutamol with the spacer. And if they're having a severe asthma attack, so any of these kind of yellow or red signs, then give them it via a nebulizer. You can also add in ipratropium bromide if they've got a poor response to that, like salbutamol, but make sure to give them steroids as well. So the mainstay of treatment is oxygen, bronchodilators, and steroids. So if you're seeing a child in hospital or in a GP surgery and they think they can be treated in the community, then make sure to give them a course of steroids for 3 days. And you can consider giving them IV steroids as well if they're really, really unwell with it or vomiting, where they won't be able to keep the oral steroid down. If none of that works, you'd need to escalate to a senior, and then potentially give them some IV salbutamol, where you'd have to monitor them for toxicity. And you can also, in worst case scenario, give them IV Magsulf as well, but that wouldn't be something that you would be doing as an F1. So if you see a child in A&E or in your paediatrics rotation, then there are a few things that we need to follow to make sure that we safely discharge children from hospital. So make sure that they're having their salbutamol via a spacer every 4 hours or more. Make sure that their SATs have recovered. Make sure that they know how to use their inhaler, and that somebody's taught them how to use it and reviewed it. Make sure that they've got a written asthma plan and it's been explained to both them, if they're old enough, and their parents as well. Make sure to let their GP know, which is really important, and make sure that either the hospital or their GP is going to follow them up within 2 working days or 48 hours, just to make sure they're doing okay, and go from there. So moving on to question 7, I'll give you guys a few minutes to read it, and then we'll go through the answer together. Okay, so let's go through the answer. So in this case, the answer was to give them buccal midazolam. So in this question, we're talking about tonic-clonic seizure management in the community and in general as well. So for a seizure that's lasting for more than 5 minutes, in this case it was 6 minutes, buccal midazolam is the first line treatment. So we would say that this child was in status epilepticus because their seizure has lasted for more than 5 minutes. If you've got IV access and they happen to be in the hospital, you can give them IV lorazepam, but buccal midazolam is preferred for kind of like rapid action, especially if you're in the community as well. So moving on to question 8.
Oh, I see. Okay, I'm not sure what's happened there, but let me carry on from where we were. Let me just give me a second to download the slides. Okay, it's just uploading them now. It's just processing the slides. Just give it a few minutes, and then we'll go back to the answer for question 8. Okay, so where are we up to? Everyone can see these, right? Just someone put a thumbs up in the chat. Okay. So is this just knowing the specific treatment for anaphylaxis? So it's the 150 micrograms of 1 in 1000 IM, just because that is different to the sort of if you have sort of like cardiac arrest, sort of the different dose that you would give IV. Yeah, so you just immediately give it if you're suspecting anaphylaxis. Or was it more the specific age, which was sort of maybe tripped a few people up because you at different sort of ages you have a different dose specific? Okay. So just go on to question 9, and I can put a poll out for this as well. Okay, so the answer. So 2 doses for girls aged 12 to 13. So yeah, the 2 doses are given to both boys and girls aged 12 to 13 in the UK, protects against cervical cancer and other related HPV diseases. That was question 10. Okay, it's a bit of a interesting ethical one here, but you respect the mother's wishes for the so this is sort of just the fact that the MMR, there was a lot of misinformation around it, and I guess with there's a lot of anti-vaxxers out there anyway, and that a lot of that stems from misinformation. So it's not just with this vaccine, but lots of vaccines. But if people have capacity, then people are allowed to make unwise decisions. Yeah. So I think that's the end. So we had someone say go back to question 9, explanation. Was the answer E? So the answer was C, which I agree is a bit misleading, because then this says 2 doses is given to boys and girls, which is sort of which is E, isn't it? If I'm honest, I didn't do the second half of these slides, so I'm not in the best position to sort of advise here without sort of just googling it. But yeah, obviously go off whatever the nice guidelines are for that one. But I agree that's contradictory. But I can only apologise, I guess, for the last few questions there. I think Catherine disconnected, and I haven't sort of rehearsed those slides, so I wasn't the best at presenting them. But I hope it was still useful, and it's sort of the idea of these is to sort of introduce ideas, but they're also like help you guys see where you need to sort of like where the gaps in your knowledge are. So if we can just send out a feedback form. So yeah, so your feedback's really useful for us to sort of plan these sessions, and I'll stay on the line for a few more minutes to answer any questions that anyone has. But thank you very much, and we will see you next Thursday.